It's 2 o'clock.
Good afternoon, good evening. Thank you so much for joining us for the Mpox special briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. We are joined by the main speaker of the session, Dr. Jean Kaseya, the Director General of Africa CDC. And I will now hand it over to the DG to start the session. Over to you, DG.
Good morning, good afternoon, good evening to all of you. We are so glad to resume our press conference. We are taking this call from Tanzania, and let me wish to all of you Happy New Year, and we hope that this year will be different from the last year. You'll see why I'm saying that. And because we want to have more time for discussion, let me ask the team to start with the presentation. Can we go with the, okay. Yes, the first slide, we wanted to provide an overview because this is January 2025. What happened in 2024? We want first to engage you on the fact that we see the number of events in 2024 was more than in 2023 and more than the previous years. In 2024, we had 213 events, while in 2023, we had 166. We will discuss reasons for that, including climate change, urbanization, and other public health issues. And if we see the top 5 diseases that we had, the first killer in Africa was cholera. We are not talking a lot about it, but we lost 3,747 people due to cholera. And the second one was measles, mostly our children, and Mpox was one of the 3 top killers in Africa. When you will visit us in Africa CDC and you'll attend our meetings in the Public Health Operations Center that we have, the map on your left is what will be shared with you. Every week, we are following what's happening in Africa in terms of diseases, and we know exactly what is when, where, and we can respond by supporting our member state. Second slide. We wanted to start today with what everyone is talking about, the suspected Marburg case in Tanzania. We got the alert beginning of January, and were informed that this suspected Marburg started in the Kagera region. If you see the map, Kagera is the trade hub linking Rwanda, Uganda, and Tanzania. And from the official communication that we have, we had 9 cases, 8 of them passed on, and out of the 9 cases, 5 were collected and analyzed at the laboratory. We know also the government is following around 300 contacts. Some of them are the health workers, but we have also other people from churches and communities. Yesterday, 15th of January, the official communication that came from the government was there is no confirmed case of Marburg based on the testing that they did. We are saying that Africa CDC remains committed to support Tanzania. We already provided 200 test kits to Tanzania when we had Marburg in Rwanda. We are providing a number of colleagues who are ready to be deployed if there is any need. For now, the government of Tanzania knows that Africa CDC and all other partners are committed to provide a response if something can be happen or if the government needs a specific need. Another slide, please. When we talk about Mpox, I think we are now familiar with this presentation, this slide. What is changing is in December, we are talking about 20 countries. Now we are talking about 21 countries because there is Sierra Leone that was added in this slide. And you'll see in terms of the trend, we are giving also the graph. And if we compare 2024 to 2023, there is this huge increase in terms of cases. This one is, again, a strong message from us to say Mpox still remains a major public health emergency in Africa. Next slide. As I was sharing with you, we had cases in Sierra Leone, and the government declared these cases on the 10th of January. And for now, we have 8 countries in control phase, and 4 of them without confirmed cases for more than 90 days. We are talking about South Africa, Gabon, Morocco, and Zimbabwe. But we still have 13 countries in what we call the active phase, like Angola, DRC, and all other countries, plus Sierra Leone. Out of Africa, China reported a case on the 9th of January, and I had the opportunity to discuss that with Chinese authorities when I flew to China. And we are following the support that we need to provide not only to African countries, but also to other continents who are facing the Mpox outbreaks. I think this is opportunity for us to work together and to show the solidarity that we need to bring. Next slide. This is a summary of what I was sharing with you. In total, we had 77,888 cases. Out of that, around 17,000 were confirmed. And we know we are still facing the testing rate issue. We'll discuss that when we'll go to the actions for the next 3 months, what we did and what we are doing to accelerate the testing rate. As we discussed with the previous slide, we lost 1,321 people in 2024. And saying that there is a region, Central African region, that contributed more and driven by DRC to the number of cases that we have and deaths. Next slide. For more information about the last cases, the 2 last cases that we had from Sierra Leone, we wanted to show in the map where are located these cases. And it's mostly in what we call the Western area urban and Western area rural district. And the government of Sierra Leone currently, they are following 25 contacts, and we hope that the testing rate that Sierra Leone is sharing with us, that is 97%, is providing clear information on the way the country is following this outbreak. Next slide. Now, we are so familiar with all challenges we are facing in terms of vaccination, in terms of lab, in terms of surveillance. What is the most important one in the next 3 months for Africa CDC and for the continent? The first one is to intensify the response in what we call the hotspot. We decided at IMST level to deploy a number of epidemiologists to support all of these hotspots. We are deploying 80 epidemiologists, plus those who are already there. We are also deploying 2,400 community health workers. As we see, this outbreak is mostly at community level. And we need to bridge communities to health centers. And having trained and capacitated community health workers will help us to respond to this outbreak. We believe by bringing this response in the hotspot, we need also to have a strong vaccination approach. Currently, Dr. Ngashi will explain to you what is the new approach for the vaccination, because we are not just vaccinating contact, now we'll be vaccinating the whole region where we are reporting cases. We are also supporting the comprehensive integrated case management. And what is innovative now, we saw that measles remain a major issue in Africa, and many of our children are dying due to measles. Why we have just to come to support the response against Mpox without providing response against measles? This is why we are having this integrated approach in terms of case management of all diseases by bringing the medical, nutritional, and psychological component. The testing rate is a major issue, as we discussed. Now, Africa CDC, discussing with countries, we agree to decentralize the testing and the laboratory. We have a clear approach, what must be where, and we are providing appropriate tools and machines to countries. I was in DRC beginning of 2025 to support with qPCR that must be deployed in some regions, and also genomic sequencing capacity at INRB level. We believe if we manage to decentralize the laboratory system in DRC, in Burundi, in Uganda, these are the first initial countries, we can increase the testing rate and know exactly what is happening, and also provide appropriate response. When we talk about community focus, we talk also about women and about youth. We know that our young people are so innovative, and we want to give them opportunity to use their innovations that they are putting in place, like mobile phone and other tools that they can bring and applications to track Mpox and to help us to stop the what we call the fake news and the misinformation around Mpox. With these 5 areas of response, we believe from today to March, we can see an increase in terms of response and more likely a decrease in terms of cases and deaths. I will stop here for this presentation today by hoping that we can now have opportunity for discussions on the way we can move on with all of these diseases that we have in our continent. And we are ready with the team to respond to your questions. Over to you, Margaret.
Thank you so much, DG. Let's take the first 2 questions from the floor. Janice from Bloomberg, you have the floor.
Good afternoon and welcome back to everyone for the new year. Thank you for the briefing. I'm really just wondering if you could give me some sense in terms of Rift Valley fever. I am aware of the outbreak that was declared on January the 10th in Central African Republic with 8 cases and 1 death. I'm trying to get a little bit of information about a vaccine being developed for that, where things are at in terms of a vaccine for Rift Valley fever.
Thank you, Janice. Let's take the next one before DG comes in. We have Sarah Jerving from DVEX. You have the floor.
Much for the presentation. Can you please elaborate why you think the health emergencies were higher last year as opposed to the previous year? Additionally, can you speak specifically about cholera and how it's manifesting across the continent and kind of the challenges in containing it? Thank you.
Thank you. Over to you, DG.
Thank you so much. I'm here with colleagues from IMST. Then I will hand over to Dr. Merawi for the question from Janice, and then we'll respond to the question from Sarah about the cholera outbreak. Over to you, Dr. Merawi.
All right, thank you. Thank you, DG. Thank you very much for that question regarding Rift Valley fever, which is still under the first 4 cases are reported with disease, which we are really following up regarding Rift Valley fever. As you know, this is more zoonotic disease, and we are currently following, which is still in progress. Control measures are taken as a case management and monitoring of cases hospitalized in one of the general hospitals, and active case search is being ongoing with active case search at a community level and public awareness on Rift Valley case definitions ongoing there. So this is currently under investigation and monitoring. We shall give you more details as we go along on this area. Thank you very much.
Thank you. In terms of cholera,
Yes, thank you very much.
I think we lost the sound. Dr. Ngashi?
Yes, can you hear me now?
Yes, we can hear you.
Okay. Now, on cholera, I think this is one of the most common outbreak on the continent, on the African continent, which affected in 2024 countries in Central Africa, in West Africa, in East Africa, as well as in Southern Africa, and also with very high mortality. I think that was observed. I think the causes, it's a combination of the consequences of the global warming, on one side with the flooding, but also combined also with the poor conditions of water and sanitation, I think in most of these countries. But I think that's what explains why we are having these recurrent cholera outbreaks. But at the same time, also the high mortality is the combination also of the weak health system with the quality of care and the lack of the key supplies that are needed really to provide quality care to these people that suffer. I think that's the reason why when you look at the data that was presented by the DG, you saw among the confirmed cases, we had more than 10% mortality rate. I think that was reported. I think that's what we can say. It's one of the priorities that is going to be addressed both from the global warming in terms of the preparedness that we need in those countries, and also ensure that one of the key things we need to address is the availability of clean water, in those, but also pushing the main challenge that remain the availability of cholera vaccines that we've had Africa CDC trying to push. That is one of the vaccines that we like really to accelerate through the local manufacturing to ensure that we have the capacity to produce locally to be able to respond to the growing needs of Africa when it comes to cholera outbreak. Thank you very much. Over to you.
Thank you, Director. Just to complement Johnny's question, we know that we have a clinical trial that started with the RVF vaccine in Kenya, the phase 2 of the clinical trial, funded by CEPI and conducted by Oxford, developed by Oxford. I think we'll provide more information about this vaccine when we'll be finalizing the clinical trial phase 2. Over to you, Margaret.
Thank you, DG. Let's take the next two questions. Carmen from Politico, you have the floor.
Thank you so much, Margaret, and Happy New Year to everybody. I had a question on Mpox. Over the holidays, there were a few reports, media reports from the ground saying that the vaccination campaign was pretty sluggish and that, particularly in the DRC, the vaccines that were available in the country hadn't been fully used. So basically, that had to happen before new vaccine shipments would come in. So I was wondering if you could provide an update on that and where we are also with the LC16 vaccine shipment that I think we were talking about just before the holidays. Thank you.
Thank you. Let's take the next one before the response. We have Esther from SciDevNet. You have the floor.
Thank you very much, Margaret, and Happy New Year to you all. My question is about the 80 epidemiologists and the 2,400 community health workers that are being deployed in DRC, Burundi, and Uganda. Are these coming from our countries, or Africa CDC has its specific people that they are deploying in these countries? Because I don't think we have these numbers in these three countries. And then secondly, I am asking, I wanted to speak about measles as a major issue in Africa. You said we have the numbers rising. What happened to our vaccination in terms of vaccinating our children for measles? Don't we do that? Have we gone below levels that are sustainable for us not to have the disease go, in many places? Thank you.
Over to you, DG.
Thank you. I will start and then colleagues from IMST will complement. Regarding the media report, yes, we saw this media report, and we want to commend countries for the effort. I think we saw what happened in Rwanda, in Nigeria, in DRC, mostly in the eastern part of DRC, where we managed to reach more than 100% of our target. Then in Kinshasa, we started the vaccination campaign. But as we said, there is a new strategy for vaccination. We are taking advantage of availability of vaccine and acceptance of the vaccine, because it's not about refusal of vaccine. It's about the approach that we're using. Dr. Ngashi will talk more about it. Second, about the LC16 vaccine, I think we had good news from Japan, and even training was conducted, and this vaccine will be available end of February, beginning of March, for our children in mostly in DRC. We are talking with Japan if we can also have this vaccine for other countries affected. I will hand over to Dr. Ngashi to talk mostly about the current strategy of vaccination that we adopted together with member states, and also to talk about the colleagues that we are deploying to support, mostly the AT epidemiologists and also community focus. Over to you, Dr. Ngashi.
Thank you very much, DG. I think on the vaccination, I think that's correct. We all got concerned, I think, toward the beginning of December with the slowing of vaccination. DRC had received 365,000 doses of the MVA vaccine. At the time, they had only used 55,000, which means that there are about 310,000 doses that were not used. But then, since then, I think some effort has been made to really accelerate the speed of vaccination. By last week, they had reached 175,000 doses that were administered. Just say that now slightly below 200,000 doses that are remaining. But at the same time, they have also revisited the vaccination strategy. I think for us, the IMST, we have discussed a strategy that has, first of all, grouped the countries in 4 different categories. We have the 3 countries that have already started vaccinating. That's Nigeria, DRC, and Rwanda, where we really need to look at the current strategy and see how to help them accelerate. We have the 6 countries that had received an allocation, but they haven't yet received the vaccines in country because of some of the documents that were required for them to allow them to receive the vaccines. We have, finally, we have another group of countries like Angola and Ghana, which had no allocation of vaccines yet provided to them, but they have requested and are still waiting for the next allocation, for which I think they're already lined up for the next allocation to receive. But for the first category, DRC in particular, the big change is that the strategy they were using was based on contact. As you know, out of the 11,000 cases that were confirmed in DRC, they only identified 15,000 contacts. You can imagine that 15,000 contacts were not enough really to absorb the 190,000 doses that are left with. Now, the strategy they have now identified with the support from the IMST is to focus on the hotspot catchment areas. So that where most of the cases are coming, I think the strategy will be to sweep the entire villages and communities that are most affected. I think it's more a geography kind of focused approach instead of the contact focused approach. But in those catchment areas and communities where there are sporadic cases, effort will be made then to go and identify those contacts around those few cases and vaccinate them. Now, with this, I think they will be able to move again much faster than they have done in December and beginning of January, where they have vaccinated about 100,000 people. I think that's the strategy now moving forward that will help really move much faster, absorb the vaccines that are left, and then also get the remaining of the allocation, which hasn't yet reached the country. And then on the question about the 80 epidemiologists, I think most of them will come from the respective countries. Africa CDC has already employed different epidemiologists during COVID-19. We had the SLL epidemiologist. We also have hired epidemiologists in the context of the AVOC program. It is building on those that we've identified epidemiologists that will be posted. But where we did not get enough from the country itself, we've also looked at the language, at least to ensure that the Francophones from other Francophone countries can be deployed to DRC and Burundi, and the Anglophones that have been used in the SLL program and other program can then go to Uganda. I think that is the current approach, prioritizing first of all the country itself, where the country does not have enough, then expanding to get from the other country that can come. But for community health workers, all of them will come from the local communities. Because in all these countries, we do have national community health programs that involve community health workers. In Uganda, we have the village health committees, teams. In Burundi, we have the community health workers. In the DRC, we have the village health committees. It is from those different structures, people that already know the context, know their areas, are the ones that are going to support this acceleration phase. I think that's what we can say on the human resources that are going to be hired for acceleration. Measles, can you answer it?
You can come here. Yeah. They know that we are in the field.
Yes.
Yeah.
Yes, thank you very much. With regard to measles vaccination, we have been tracking measles across over 20 countries that are occurring for the last 1 year. And this is with multiple reasons. One is the slide down of vaccination during the pandemic period. Now, different countries have initiated to catch up and follow up vaccination. Africa CDC is monitoring that. And when there is an outbreak that surges up much aggressively, we support initiative of outbreak response vaccination for measles. Currently, we are supporting the routine and the catch-up and follow-up vaccination initiatives of different member states. Thank you.
And just to add something, DG, on what Dr. Merawi says, that during the Mpox response, the surveillance has also revealed that in a number of provinces and districts, we see the concomitant existing of both Mpox and measles outbreaks. Now, I think that's why we're now talking about an integrated approach, which means that as much as we'll be addressing Mpox, where we've seen also measles coming, we'll also have a response to address measles through vaccination, case management, but that starts right from the diagnostic to make sure that we also have the diagnosis of Mpox negative cases might be confirmed, they can also be taken care of. I think that is the new approach, of the second phase of the response in January and February, which is going on to take into consideration that reality as well. Over to you there.
Thank you, Margaret. Over to you.
Thank you, DG. Let's take the next two questions. Priyanka from New York Times, you have the floor.
Hi, thank you for taking my question, and Happy New Year to everyone. I was, please help me understand in case I'm getting this wrong, but the 5 samples that were tested from Tanzania for Marburg weren't positive for Marburg in the lab. But it's suspected that it's Marburg because of the symptoms that have been detected. And my second question is regarding the unknown illness in DRC in the Panzi region that we were discussing last year. We had talked about severe malaria, influenza. Are there any updates on that end? Thank you.
Thank you. Let's take the next one before the response. Dorcas from BBC, you have the floor.
So Happy New Year, everyone. So just to echo what Priyanka has asked, is it too soon to rule out Marburg at this point? Because if 5 samples were collected, we have 4 other samples. And also, which other viral hemorrhagic fevers are the health authorities, including Africa CDC, WHO, and the Tanzanian health authorities considering? And then my second question is on Mpox. Where are we with regards to the vaccination in Burundi? I remember last year, there was no allocation for the country, if I remember correctly. And Africa CDC was also following up on Kenya, because initially the Kenyan government had announced that there would be vaccination in December, but then again, there seemed to have been a bottleneck. And is Uganda getting an increased allocation? And lastly, on the childhood vaccination, is it just LC16, or are we also looking at the Bavarian Nordic for children also below the age of 17? Thank you.
Thank you. DG?
Thank you so much. I will start with some of the questions from Priyanka, Dorcas, and then my colleagues, they will provide some additional information. We need first to share